Good afternoon and welcome everyone to this patient-focused webinar. I'm Katie Davis from Insightech, and I'm pleased to be part of today's virtual educational event. Please be patient as we take a few minutes to allow everyone to get signed on. The presentation will begin shortly. Good afternoon and welcome everyone to this patient-focused webinar. My name is Katie Davis from Insightech, and I'm pleased to be part of today's virtual educational event. Please be patient as we take a few minutes to allow everyone to get signed on. The presentation will begin shortly. Looks like we have a good number of attendees signed on, so let's begin. The goal of today's presentation is for educational purposes. We're very fortunate to be hearing from Dr. Krishna and Dr. Roque from the University of North Carolina at Chapel Hill as they discuss treatment options for essential tremor, specifically the medical treatment of essential tremor with a special focus on occupational therapy. As questions arise during the presentation, please utilize the Q&A button located at the bottom of your screen. We will have time after the presentation to answer the questions that are asked within the chat. Let me begin by introducing you to today's presenter, Dr. Krishna and Dr. Roque. Dr. Krishna is a board-certified neurosurgeon with expertise in functional neurosurgery and neuromodulation. Dr. Krishna treats patients with movement disorders, including essential tremor, Parkinson's disease, and dystonia. He is an early adopter of focused ultrasound technology and is considered a thought leader in this field. As a surgeon scientist, he focuses on research to optimize the focused ultrasound technique to improve patient outcomes. Dr. Roque is a board-certified neurologist and movement disorder specialist with specific expertise in diagnosing and treating multiple tremor syndromes. His clinical and research focus is on the improvement of tremors through both traditional and innovative methods, seeking out quality of life initiatives for patients with movement disorders. He serves on multiple regional and national forums aimed to improve outcomes for tremor management. Welcome, Dr. Krishna and Dr. Roque, and thank you so much for presenting this afternoon. The floor is all yours.
Thank you, Katie. We want to welcome all the patients and family members who are interested in participating in this educational activity. We are grateful for your participation. We would, when we thought about the series, the webinar series, each one of these webinars has a different flavor to it. And the idea is for us to take you through all the different aspects of care, including medical, surgical, and the emerging treatments. And what we would do is towards the end, we would have a summary webinar that would summarize all the major aspects of the education that we had discussed. So it's a great pleasure for me to have here my colleague and partner in neurology, Dr. Danny Roque, who is a movement disorder neurologist with special emphasis on hyperkinetic movement disorders, including tremors. And so he is a very unique resource for not only UNC, but the surrounding area where all the complicated patients who present with tremors are sent over to Dr. Roque to talk about characterizing the tremor and also the treatment options. So not taking more time. Welcome, Dr. Roque, and we look forward to hearing about the medical options.
Thank you so much, Dr. Krishna. I appreciate it. And so I am starting off the presentation, hoping everyone can see this. There we go. So pleasure, everyone. As everyone said, my name is Danny Roque. I'm an associate professor at the Department of Neurology at the University of North Carolina. It's a pleasure to speak to everyone today about the medical treatment options. And as Katie said, this focus as well on occupational therapy, which really should be rolled in very well into these sort of a more conservative approach. What are options that we could take when tremor is present, and perhaps especially in those more mild to moderate stages? So this is just to sort of walk folks through my general disclosures. I do provide educational forums and some consultations. But the goal of today's talks, I'm hoping to bring everyone up to speed with how we go about distinguishing different tremor variations and how this helps guide treatment choices. Excuse me. Medications that we could use to reduce different kinds of tremor. And then, as I mentioned, the role of occupational therapy. And by the end of this, I also hope to show everyone our full team and kind of how everyone's integrated at our center for evaluating and treating patients with tremor. So let's start with a discussion on the types of essential tremor. And since this is a bit of a focus on essential tremor, we have to start with understanding that there are updated diagnostic criteria. This is not very well known, even though we've been in this state for roughly now 6 years, which is that in order to qualify for this diagnosis, we need to start with having had tremors in both arms with action. And I'll describe what that means in just a moment here. It could include tremor in other locations, and it didn't have to start with tremor in the arms for that matter. But in truth, we need to start the clock with where the arm tremors develop, because the arm tremor must be present for at least 3 years before we can feel confident that we have the right diagnosis. The main reason this occurs and why these diagnostic criteria were developed is that we went a solid 30 years trying our best to characterize this in the international community and finding that too many folks were getting the wrong diagnosis early on, turning out to have a different condition, explaining their tremors. And that beyond this is that we don't have a better test other than a good history and a very careful examination to tell us what the right diagnosis would be for a tremor. Unfortunately, there's just nothing more that gives us that information, although I'll describe a few items that we do use to help us along the way. So I mentioned that this is present with action. So to review the action tremors, we'll start with the 2 types of action tremors, which are postural tremor and intention tremor. Postural tremor occurs immediately upon holding a posture or a fixed position of an arm, of a leg. Examples of this are when folks are grabbing and holding onto a book in that given position, holding a plate steady, trying to hold it steady when you're otherwise traveling. But the point is the posture within the limb, so the arm or the leg, is held fixed, and that tremor shows up immediately upon putting that posture into place. Then there's intention tremor, another kind of action tremor where the shaking occurs in motion to a given target or location. So this is where a lot of the kind of fine motor skills we talk about in essential tremor come to pass. So writing or performing calligraphy, reaching for items in a cupboard, threading a needle if you're doing any crochet work. So these are good examples because they're very much in the midst of performing a targeted activity that is not just a fixed posture. So the impact of tremor on function, I mean, folks who are on the call who experience tremor will know this better than most, but the truth is healthcare providers are a bit trained in the way that we approach asking questions about where there's an impact of tremor on your daily activities. This includes the discussions on handwriting, discussions on eating and drinking, whether there is a social stigma or embarrassment associated with the tremor. These are very commonly asked by providers. But what isn't commonly asked are some of the more technical, highly fine motor skills and hobbies that we otherwise pick up along the way that you would need to bring to your provider's attention in many instances to indicate just what that impact looks like. So often forgotten are going to be things like using a lot of technology, computers, using keyboards and mice, cooking, preparing food, doing housekeeping, chores. In terms of transportation, some folks feel the difference in the midst of holding onto a steering wheel or manipulating the stick shift. So, and then using a telephone, especially with smartphones nowadays, certainly this is something that comes up pretty darn commonly. But not all tremors are created equal. So again, coming back to show what we do on examination to try and parse some of this out, we ask folks to extend the arms in front of them in order to see how tremor develops in that position. Other times there is this so-called wing beating tremor, where if you're asked to bring your elbows out to the side, you can see tremor more prominently there. This tremor actually, the reason why this occurs, in fact, is because many folks may have discovered along the way that they can bring their arms into their core and reduce how much of the impact their tremor has. But the moment you have to bring the limb away from your axis, from your core, the harder it is to do that because the tremor signal comes through your arm or your leg. And then intention. So this is very much back to the idea of reaching for targets. So you'll see providers will use a finger to nose test. So having you touch your nose, touch their finger, or if they're kinder, they'll have you touch your chin so that you're not smacking your nose in the process of otherwise trying to reach for it. And then there's another kind of tremor found in essential tremor, but is a crucial difference in terms of the way we manage this, which is a rest tremor. Now, the term rest tremor is often brought up in the context of Parkinson's disease, but it is not unique to Parkinson's disease. In fact, up to a quarter of folks with essential tremor can experience rest tremor. The tricky thing here, though, is it doesn't always show up just when you are relaxed and otherwise not moving, but it can be the case that when you hold a posture, the rest tremor comes through that posture after a second or more, maybe within a few seconds, but it can be just about a second later where it truly shows up, where it otherwise grows in how large the tremor is over the course of several seconds. So this is more consistent with a rest tremor or so-called re-emergent tremor. As I mentioned, about a quarter of folks with essential tremor can experience this and never specifically develop Parkinson's disease, but simply have two kinds of tremor. And the treatment here is more along the lines of what we give folks who have Parkinson's disease. The medications available for essential tremor just don't quite cut the treatment management for this particular tremor. But when we have concerns, perhaps, in the event that we're early on, it hasn't even been 3 years yet with someone with tremor, and we think someone might have essential tremor, but also has some features, not just rest tremor, but maybe other signs or symptoms of Parkinson's, we can use something called a DAT scan, which effectively allows us to try and better quantify, so find a way to more objectively determine, aside from examination, whether perhaps there are two conditions at play, because it does occur. In fact, roughly the estimate is that roughly a six-fold increased chance of developing Parkinson's disease in essential tremor as compared to the general population, which roughly estimates out to about 5% of folks with essential tremor when you do some of that math. So still not a large number of folks, but because you can have both conditions, sometimes this is a useful tool to parse this out for your providers. Not used regularly by any stretch, but available. And especially could be helpful, as I mentioned here, in terms of driving medical decision-making if at all necessary. So coming into that, understanding tremor a bit better through those slides, I'm hopeful now that we can talk more about what should we do in terms of medication. So first is the more traditional approach. They all available medications fall under symptomatic management. So the medications we would use in all these instances don't change the course of your tremor syndrome. They don't make it any shorter. We don't have cures for these. And they don't slow anything down. They simply are there to try and help you reduce how big or how large the tremor appears. The best suppression that we can achieve really does depend on the kind of tremor that you experience. So is it mostly postural, mostly intention? Again, re-emergent or rest tremor, so that we can hone in on the right treatment options there. The tricky thing that we have at present with essential tremor in particular is that none of these medications were ever designed for tremor inherently. They are all medications along the way found to be useful, and so for that reason approved, but they were seizure medications or blood pressure medications at some point in the past, and we're just have them available. And for some folks, they really can make a dent. So the fork in the road, first and foremost, from our perspective, is understanding whether someone has mostly postural or mostly intention tremor. For some folks, it's a bit equal, and that's okay. So we can kind of parse through maybe a combination approach as opposed to just a strict one-sided approach. But if there is more postural tremor than intention tremor, then some of the best data would suggest to us that the beta blockers like propranolol would be perhaps a bit more favored. Just because we have found it to be more useful more often than not in the postural component. While we're at it, it can help with anxiety. It can help reduce blood pressure if you need it, but it can also reduce heart rate in a significant fashion, make it difficult if you're an asthmatic or have emphysema or chronic bronchitis, can impair breathing tolerance, and that also goes for exercise. If you're big into cardiovascular exercising, it can make it hard to do so because of shortness of breath. Then there's primidone, which similarly is found to be better for postural tremor than intention tremor. And these are not exclusive comments, but they're just tendencies. So again, we could use a primidone. It's a long-lasting medication. The propranolol, there is a long-acting formulation as well, but that's roughly a 24-hour medication, whereas primidone lasts about 1 to 2 days once it's steady state in your body. But it can be sedating. It's why we definitely dose these at night. Some folks will find providers who will try to dose them in the morning. And if you can get used to that, the question is whether it's additionally beneficial to take it in the morning versus just dosing everything at night. Then if you're focused more on intention tremor, right? Postural tremor is not nearly the problem you have. Then we do call this medication a second-line therapy, but again, we find that intention tremor responds better to Topamax or topiramate. This is a medication that in the 90s was incidentally found to also be useful for tremor, not unlike our previous experience with the other two meds. And while we're at it, it's a medication that can be useful for migraines. So if someone suffers from migraines and tremor, it could be a nice 2-for-1 combination. Even at low doses can be helpful, although the dosing regimen for Topamax for tremor requires at least twice a day, more often 3 times a day, because the effect is only about 4 to 5 hours long. Now, the bad thing here is you see a few comments like kidney stones. If you don't stay well hydrated, you could develop kidney stones while on this medication, which would not be great in any respect. Some folks can experience at higher doses of Topamax word-finding difficulties, and I already mentioned the frequency. Then there's more advanced therapeutic approaches. This is still technically under investigation, though it is available on the market. Focal neurotoxin therapy or botulinum toxin. It's been a long time in the making, and there are folks who feel very confident and comfortable being able to provide injection options for folks, which in fact, what it's doing downstream, you're injecting muscles inside of the arm or forearm to reduce their strength just enough so that extra signal, like a tremor, doesn't get through, but you're not so weak that you can't use your arm, because sure, maybe we can make the tremor better, but at what expense, where you can't use the arm because it's too weak. So finding that sort of happy medium. That said, it does require, if you approach or use this technique, it will require a re-injection every 3 months, because the effect does wear off over time. And as I mentioned, it's still under active investigation, so we'll see. Maybe the FDA will have more commentary in the coming couple of years. So then, what do we know about the success rates of these therapies? So when you look at the independent scores for independent medications, you'll identify quickly that the chances that this is a recovery. So this is not a how much it reduces the tremor. It's actually the chance that there'll be a reduction in tremor. So the chance there'll be a reduction in tremor for primidone is about 55%, a chance for propranolol 60%. And then if you combine the primidone and propranolol, this actually increases to 70%. So for some folks, if you're only on one and you haven't tried the other, there could be value to being on combination therapy as an option. But again, speaking with your individual providers about this. Again, if you have mostly intention tremor, Topamax may be a reasonable pursuit. And the available data here tells us that physicians see more of a change than patients do on the medication. So just keep that in mind if that's an option you wanted to pursue. And then when you look at medications which are used, especially in primary care, like gabapentin and clonazepam, these are meds that have been on the market for a very long time, used for many different reasons. But it has not been shown to be clearly useful in the available publications and literature that we have available to us. And then what about the reemergent tremor or rest tremor, right? So I mentioned that that has a different treatment modality, and it is true. So we would use the traditional meds we have available in Parkinson's, levodopa being perhaps among the most utilized in this scenario, but actually only has about a 40% success rate. Then there's a category of medications like ropinirole or pramipexole called dopamine agonists that can have up to a 60% chance of having some successful reduction in tremor. Amantadine has a bit of a higher record there, but it's still no greater than 80% chance, whereas Artane is a medication, again, been around for a long time, and it is considered the most potent medication to reduce tremor, especially rest tremor, but arguably, if you really needed to, you can consider it for essential tremor as well. We will use beta blockers occasionally for this because you can see a reduction in just the reemergent tremor with medications like propranolol, but that rate's even lower than what we see in essential tremor. So it could be useful sometimes, but we don't often pursue it. And in truth, if you look at the real data, there's insufficient evidence that any of these meds clearly benefit reducing tremor reliably, but these are mostly the published information we have to share with folks to say, hey, there's something we can do here when it comes to meds, but just temper your expectations when it comes to successfully suppressing the tremor, because that could be quite difficult to perform. So then this leads me out of medication options and into more of the role for occupational therapy when we're trying to manage tremor. So where can an occupational therapist really be helpful? It's in the goals of care. You can use specific tools and tasks and methods provided by an occupational therapist to help your specific everyday activities or so-called occupational efforts. And what they're doing is they're going to work on physical and mental ailments, which quite frankly, both might be influencing your tremor and your ability to perform specific tasks, because of course it could be inherently frustrating in the midst of experiencing the tremor as you're performing that specific activity. So this really takes a bimodal approach to assist you in those instances. They're working to develop, recover, maintain, and improve the skills needed so that you can perform those instrumental or non-instrumental activities of daily living. And the whole point here is gain independence, gain levels of independence that you didn't have before due to your underlying condition. Of course, in this case, we're talking about tremor. So when it comes to tremor management, there's been a lot of effort looking at and studying opportunities to enhance the lives of patients. There's a few activities that are reported quite useful by clients, but there are specific principles that I'll talk about here that are most notably useful and that perhaps are most commonly used by occupational therapists who are familiar with tremor, who are very familiar with tremor and who will really focus in on those pursuits more than other potential avenues. And I couldn't emphasize this enough, just like with medication, helping an occupational therapist understand what kind of tremor you're dealing with, postural tremor, intention tremor, reemergent tremor, can really help guide the pursuits of occupational therapy instead of just having a generic approach that may not be nearly as useful to you. So first, let's start with weight-based therapy. So talking about weight-based therapy, this is going to be most useful for postural tremor as compared to intention tremor. When you hold that posture, and if you apply a weight or a force onto that hand, or even technically onto the leg, but it's most commonly used in the hand, you can reduce just literally how much that tremor can impact the movement of the hand or impact the movement of the arm. And so, we're basically taking advantage of gravity in so many ways here. So you'll see gloves that get utilized for this purpose to reduce the tremor therein. You could see utensils that'll be heavier utensils, all aimed at trying to reduce how much the hand shakes while you're holding on to that utensil with specific activities, pinching your salad or pinching your different meats, holding on to soup or peas inside of a spoon. And then there are specific braces, which are a bit different from weight inherently, all aimed at specific activities so that perhaps you don't have to contract your arm nearly as much to perform that activity, lower the impact of tremor through that bracing technology. Then there is more of an adaptive equipment approach. So this is going more into improving intention tremor, less about improving postural tremor, where the tremor itself is not impacted. So the tremor remains present and relatively unchanged, but your ability to become independent despite the tremor with specific activities increases. So it's really tailored toward what your activity is that you're trying to perform. Good examples here are going to be like a gyroscopic utensil. So you're holding on to that gyroscopic utensil. It feeds off the information about how hard or how large you are shaking, and the end of that utensil will be manipulated. So it will basically be on a hinge that will rotate to your tremor frequency so that you can successfully bring the item on the utensil to your mouth. And so then another example will be what you see here on the right, which is just one way of having an adaptive device that records information from a mouse about how hard you're shaking in actually in two directions, and try to use that to reduce that signal as you use the mouse to get around your computer. So just a couple of examples, but it's using adaptive equipment instead of weight-based equipment. We're not directly impacting the tremor, we're impacting the end result, which is the activity you wanted to perform. Now, these are a couple of the most important pursuits that are used in occupational therapy. They're not the only ones, but they're the most perhaps commonly used ones for tremor management. But what is the best approach in general is actually a combination of both medication and occupational therapy. So short of going into the more surgical and more advanced approaches, combining occupational therapy with medication has actually been shown to be quite useful to improve someone's garnering of independence, despite the presence of some remaining tremor. So better that than just taking one approach alone. And we certainly try to practice that in our program as best as we can. Which leads me to then chat about our team. And we have this unique tremor clinic. It's we call it the UNC Tremor Interdisciplinary Clinic. As far as I've recently researched, still first of its kind, and not anyone else has quite taken us up on building another one elsewhere in the country. But this is a unique clinic that is trying to take advantage of the multiple specialists who are in the clinic. This includes myself, Dr. Krishna, one of our occupational therapists who's uniquely trained in tremor management, and then working with several teammates who are part of our sort of academic pursuits, which includes helping folks with their education. We have a nurse educator and coordinator as part of the program. We have a biomedical engineer who can come in and perform more biometric data analysis on tremor to help us therein. And then there are research opportunities at our facility, and we have a coordinator who helps us manage through those and identify who qualifies for any particular ongoing studies we may have for tremor. So, this is something we perform on a monthly basis. We're actually hoping to increase the frequency of this in the coming future. And all of this is, you can imagine, with a once a month and even perhaps a twice a month clinic, our goal is to educate and to really educate not just you, but your team, your care team, which is going to include perhaps your local neurologist, your primary care physician, your local therapist who might be, occupational therapists who may not have enough information on what could be performed, what could be practiced. So we hope to be able to share that with your community and your care team. And with that, just as a short reminder, these are certainly options. All these treatments need to be tailored, but tailoring treatment specifically to someone's underlying tremor syndrome and identifying that accurately is going to be key, important, whether we're talking about medication, occupational therapy, or ultimately surgical options. So I will stop here. Thank you very much, everyone, for your attention, and we'll entertain any questions.
Thank you so much, Dr. Roque. That was amazing. And I know we had some questions kind of come in here, and Dr. Krishna has been answering them. But one that we get a lot, so I just want to make sure that we voice it for the team, is when we're talking about essential tremor and the symptoms, we talked a lot about that hand. What about patients that have head tremor as a result of their essential tremor and voice tremor? What would be kind of your advice for patients that that's their primary disturbance or quality of life function?
Yeah, it's a great question. I wish I could say there was adaptive equipment or great looking weight-based therapy for this from our occupational therapy colleagues. But they do still provide what those folks who are subspecialized in tremor will tell you is that there are methods to kind of learn to minimize the impact on your activities. For some, and the folks on the call may know this about their voice tremor. When it comes to voice tremor, there are some folks who learn about being a very good vibrato, and perhaps sort of taking an opportunity to take that role in a choir if available to you. But in other scenarios, it is a matter about changing tone, learning that together with a speech therapist, because our occupational therapist will recruit our speech therapist when necessary. When it comes to the head, though, there is data that suggests that primidone is useful perhaps up to 40% of the time, reducing the impact on head tremor. But that's about the best we have on the medication side. There is effort, and I've done it, some of my colleagues have done it as well, which is to try neurotoxin therapy, so botulinum toxin to neck muscles to try and reduce the impact on head tremor. Our pretty common experience is that the first time you do an injection, it works very well, and then it never quite works again, at least not to the same degree as what we once experienced. And so if those are the most impacting symptoms, this is where, some of the more advanced therapeutic options, the brain surgeries really come in as considerations, although we usually have very careful discussions about that too, because even that fails time and again to provide enough of a suppression of those tremors.
Awesome. And I'm gonna, if I do not get your question correctly here, feel free to send it again. So someone talked about having the shakiness predominantly in their hands. I know in your presentation we talked about arms. Would this patient be potentially an essential tremor patient if that is in their hands and not their entire arm?
Yes, we just need them to be in the upper limbs. We're not picky past that point. So shoulder to fingertip, as long as both hands are there. We've had the 3 years under our belt. We feel without other signs or symptoms, we feel very confident that the chances this will be essential tremor is extremely high.
This is a great, go ahead, Dr. Krishna.
Dr. Roque, among the specific strategies, can you talk a little bit about some of these new advances in the equipment with voice to text or voice to dictation kind of software?
So adaptive equipment in that respect. Yeah. So there are quite a few efforts, and I have not had the pleasure of being able to sit and validate more than one of them. But the short of it is that they are options. They are available. I will have patients who bring me what they've found, in the app store somewhere, or even a product they found online. Because I will tell you, there are tons and tons of biomedical engineers out there who are constantly looking for new ways to find adaptive means of reducing your tremor. And I never find, if someone tells me it makes a difference for the tremor, that's great. I'm always personally hesitant to go translate that to someone else because of the unique nature from one patient to another. Not every tremor was created equal. So it's hard sometimes when the data is not better to be able to make recommendations to more than just that single person to keep doing what they're doing. But it certainly means that there's still effort underway, which should be reassuring to the folks out there regarding their tremor and management therein, right? We keep looking, Dr. Krishna knows this, but I'm always in a state of telling myself I'm looking to put myself out of business. I want someone to find a way to effectively reduce tremor. Gosh, if we could use the word cure, right? Like actually find a way to cure tremor, and get there, right? Get there. But so I welcome anything and everything so that we could try things. But on the adaptive equipment side, I think it's so personalized that it makes it hard to make a formal recommendation, as much as if it's not cost prohibitive to you and it looks like it's going to try to address your specific tremor type, by all means give it a shot, and it's determined for yourself if it made a dent.
Great answer. Another question, Dr. Roque, patients often ask is, how do I monitor the effectiveness of my treatment? Like someone starts propranolol, how do I know that it's working, and how do I know that it's not working beyond a certain point? So these are two answers that will be helpful.
No, those are great questions, and I do get them plenty. There's two parallel answers to that question, and I often say it at the end of any visit with someone that we do choose to start medication on. The first is there's the objective sitting in front of the patient, being able to tell them, hey, look at this testing we did today. Let's compare it to this testing in 3 months. Let's compare that testing to a year from now to see how things change while you make either no changes or some changes to the medication. So we can certainly follow that, and then I can feel good or not about the effect of those medications on tremor. But then there's the way more relevant parallel pathway to monitoring this, which is what's the activity you're looking for changes in, right? We recognize we're not going to cure this. We recognize we're not going to make it disappear. But was the reduction in tremor intruding on your activity sufficient to keep the medication on board? Simultaneous with, did you get any side effects from that medication that would tell you that, hey, I can't really get any higher on this dose, or gosh, I can't even tolerate this dose? Because there is eventually a negative return on investment with all this. Once you start getting to a high enough dose that you start getting a side effect, that side effect creates a stressor. And everyone here will feel and know that if you're stressed and you have tremor, your tremor gets worse. So you start getting side effects. The side effects cause stress. The stress worsens your tremor. And suddenly you feel that on the medication, you're actually getting worse tremor than if you were just off of it. So important things, there's quite a bit there to keep track of, but all very relevant and important to answer the question for yourself.
Jay, that's a great answer. So great way of thinking about it is use tremor effectiveness, but also look at the side effects. So that's a great point to consider. There's a relevant question to this answer that you had. Someone is asking, why can I do an activity one day? For example, when I'm putting my eyeglasses on, I'm able to do that one day. But on the other days, there's a great deal of tremor activity, and I'm not able to do that. So some days I can do that without tremor, some days I can't. So what's there in this situation?
What is the story there? So there's the honest answer of we don't know enough, and then there's an answer that's more gratifying, of course, which is to be able to say, well, day in, day out, we are human beings. We live out our lives in different means and meet different stressors day in, day out. Any stress will worsen tremor. So what I mean by this is I generally tell folks there are 3 main categories of stress. There is physical stress from illness, from pain, from underlying disease causing issues like hormonal changes, etc. Many things that sometimes are just under the hood, right? Even high blood pressure, which you may not even experience enough of other symptoms, but these are physical stressors. Then there are mood stressors, so more anxiety, depression. You don't even have to have formal diagnoses of these conditions, but nonetheless, we can have those mood adjustments day in, day out, hour in, hour out, gosh, minute in, minute out if you're not too careful. And as a result of that, those can be in either direction, can induce mood stress. And then there's more of the traditional life stress, family, work, just things you're trying to get done around the house you can't quite get to. And so any combination of these, they build on your total stress load. And so the thought is that that stress load will fluctuate day in, day out, and your tremors may fluctuate along with them. It's an easy thing to say, and I will have many patients who can find those stressors along the way and how that might correlate with their tremor. But I also have patients who can't find that. And so That's why it sounds gratifying, but if we're being honest with ourselves, it doesn't give the full picture, and we don't actually have the full picture as part of the problem.
That's great. The next question is about, I noticed that focused ultrasound hasn't been mentioned. Does UNC support this form of treatment of non-surgical intervention to deal with essential tremors? I can answer this question. And so the specific topic for this webinar was medical treatment and occupational therapy. And so we intentionally left focused ultrasound out from this talk. We want you to know that we do this focused ultrasound treatment, we do DBS treatment as much or probably more than other colleagues as well. And we fully support it and specialize in it and take pride in doing it really well. And so for specific discussions about focused ultrasound and DBS, I think we should mention that we would have another webinar. We would love for you to join in and actively participate. And so I hope that answered the question.
And I'll piggyback off that to say, just as much as we can offer those as other tools to help manage folks with tremor, they are not cures. Neither of those procedures are cures, and they are tailored, right? The way when we evaluate patients, and we certainly expect our colleagues would do the same out in the community, where you want to know that your treatment, your advanced treatment option, like focused ultrasound or deep brain stimulation surgery, are being tailored toward your specific kind of tremor, that the first step is that we've cleared these steps first. Not necessarily, I mean, depending on the scenario, maybe meds have been tried, maybe they haven't, maybe not the right meds have been tried, maybe the right testing hasn't been done. Get this part down first before you try to move into any state of considering surgical options, because focused ultrasound, deep brain stimulation surgery, it is considered more advanced for a reason. So we are very thoughtful about these approaches to get it right as often as we possibly can.
Excellent. Next question is about the tremor phenotype. The question is, my tremor is much worse in the left side, but on the right side, it seems to be moderate tremor. Is this common?
Yeah. So the last check on this was actually just in the last 4 years, where asymmetry, so one side tremor is worse than the other, is perhaps the most common scenario. Now, significant asymmetry, so having one arm that's very bad and the other arm be minimal in terms of any tremor, that's not nearly as common. That's probably under 10% of cases. Whereas some discrepancy is certainly allowable and doesn't change the definition or the criteria we use for essential tremor. But the other caveat to this, though, is that I have had many a patient walk in saying that their dominant hand is much worse than their non-dominant hand, only to discover that really the non-dominant hand is actually worse or the same. It's just that you are so reliant on your dominant hand that the impact is always larger on your dominant hand. So I understand that, but then when we're being more objective about it, it's actually closer to the same than we realize.
That's a great nuance that you mentioned, Dr. Roque, about the impact of the tremor and the tremor severity. And then sometimes you have to kind of tease it apart. How severe is tremor on one side or the other, and how much impact it's having in your quality of life. And at the end of the day, we kind of value more towards the impact that the tremor is having, and then tailor the treatment according to that. Okay.
Yes.
We have a question that says, I have had focused ultrasound treatment on my right side. I still have residual tremor on my right hand and neuropathy in the fingers. Would OT help with this? So that's a good question. And what I would encourage you to do is kind of reconnect with your treatment team that treated with you with focused ultrasound, and get their thoughts on the residual tremor that you have and what can be done to help with that. The way we think about it, about tremor coming back after focused ultrasound treatment, you have to understand the timeline of that. And so if the tremor came back, say within the first 3 months, There could be a different reason for that, versus if the tremor came back, more towards 1 year, or if the tremor came back after, say, 5 years. And so we have to kind of understand where in the timeline you are from the treatment. And certainly occupational therapy can help in any stage, right? So Dr. Roque talked about occupational therapy being helpful before, while you're doing medications, together with the medications. And we would even venture to say that once you're having, say, the consideration for surgical treatments, even afterwards, it helps in all the phases. So certainly worth trying. As far as the neuropathy part goes, we'd have to sort of characterize, what kind of neuropathy is this, and then understand, what that involves. Sometimes, if neuropathy leads to loss of sensation, occupational therapy can help you devise strategies around that and help you with that aspect. Next question is, I live in Bluffton, South Carolina. It's close to Hilton Head. I know Bluffton, South Carolina. I did my residency from MERC. So that's my part of the country, and so that's home to me. Yes, and so my hands shake, and not all the time, but under stress, holding knife and fork. Yeah, certainly. There are centers that provide help for patients with essential tremor. MERC certainly is a great center and has a long track record of providing treatment for patients with tremors. You can certainly seek help at MERC. Great movement disorder program. We have colleagues there. And if you're interested in focused ultrasound, MERC patients do come to UNC to get focused ultrasound treatment. So we have great collaborative working relationship between the two institutions. And so if that were to become a case, we would love to help you out with that aspect. But certainly there are good centers in both South Carolina and North Carolina to help you with this. And the next one is, if not already answered, how long does focused ultrasound results last? And I think there's a related question to that. What's the success rate of DBS versus focused ultrasound? So I'd have Dr. Roque kind of mash these together, even though we are not talking about surgical treatment. Maybe in a few minutes, if you could just summarize these two questions.
Sure. To be short, there's a lot. This could be an hour-long discussion, as Dr. Krishna knows, but the long and the short is, we do have data that tells us that we can get years of benefit from tremor suppression from focused ultrasound. We also have data from deep brain stimulation surgery of the same, and in fact, some of that data, just because the surgery has been available for much longer, we can actually see how we are able to sustain that benefit, and some of the data actually gets published out about 15 years, coming into nearly 20 years for some folks, with updated technologies and the like. So, we are in a constant state of finding ways to maximize that number, and that is true for both procedures. And we have the benefit of having a lot of good thought leaders, and in both here at UNC, but also across the nation, that we get to collaborate with on ways to maximize that number. So that just because you see a specific number published out there doesn't mean that we aren't working hard to maximize that time from focused ultrasound in terms of how long that benefit lasts. So we keep working toward it, so that it's not just something that you're going to have to come back to do within a year or 3, right? That it's something that's going to be longer lasting.
Thanks, Dr. Okay. And so just to summarize that, the idea is not that this is going to last a year or 2. When we go into focused ultrasound, we are going with the intention this will be durable results. And the idea that we only have 5 years, the technology has been around for only so long. We've had the results up to 5 years after the treatment, and we hope to develop this experience into the same pathway as we did for DBS 10, 15, 20 years. Okay. There is a question and a observation by patient says, I found with trial and error that when I'm going out for example, for a dinner with the neighbor, I generally have success in using a combination of propranolol, acetylene I-carnitine, and CBD to control my tremor. So it's a combination of all these 3. What are your thoughts on that?
We are in the good state of North Carolina, where I only get to make certain comments on these kind of things publicly. That is great to hear. Folks can't always find that kind of success from a combination of over-the-counters because N-acetylcysteine as well, and certainly CBD. These are things that are not always easy to, one, come by, two, have any consistency in the way these are manufactured. So it's really tricky. The data is very conflicting and confusing, and it has a lot to do with, which is, by the way, is not even much, but what is there would suggest first and foremost, and perhaps most predominantly, that especially on the CBD side of things, we are probably first and foremost impacting stress. So we're probably impacting things like mood stress, anxiety, and things of that nature first, which we know has a negative impact on tremor. So perhaps the next step is the tremor actually looks better because we're less stressed in the process of approaching that scenario. But that it has a clear direct impact on tremor, the data is conflicting at best.
That's great. While we are sort of coming to the end of this webinar, I want to ask you a question about, thinking about some of these treatments. Do we have a sense whether any of these treatments change the progression of these disease? We talk a lot about this in Parkinson's disease, which is progressive disorder more so than essential tremor. But within the context of essential tremor, do we have a sense whether these medications and interventions have any disease modifying effect?
It's a great question. The hardest part with this, of course, is that when it comes to essential tremor, we don't have a great, other than an exam, we don't really have a great way of following someone over time to know how things might be progressing. The best data we have on this as well tells us that essential tremor is a progressive condition. It's just that it progresses quite differently, even within members of the same family who suffer from essential tremor. So for anyone who's heard me say this before, it is very common for me to encounter a family where one person started having tremor in their 30s, progressed very slowly over 30 years, another person who started in their 50s in the same family who had a rapid progression of symptoms over 5 to 6 years, and then sort of stagnant for 10 to 12 years. And then someone who started with very severe tremor within a year at the age of 9, and then experiencing a very stagnant course until their 20s when they finally started seeing progression. So those are a lot of examples to paint the picture of this is a progressive condition, but just the way it progresses is so relatively erratic when you're looking at a large group of people with essential tremor. So I will tell you that what that has done to the community is make it, we thought before that we understood how to follow these patients, like in Parkinson's. We thought we knew how to follow them and understand disease progression. But because of how erratic that is compared to Parkinson's disease, which is much more predictable, and even then is not terribly, it's just much more predictable comparatively speaking. We've not abandoned the effort, but we had to hit a major reset button, and we haven't gotten past the reset button. We don't quite know how to analyze this, how to answer this question as an international community just yet, because we need something better than just following someone's tremor over time to help us answer this question.
So Dr. Roque happens to be serving on the Movement Disorder Society's Tremor Research Group. And so all these questions are giving him the research questions and research focus for the future, Dr. Roque. So this is great experience from here. So one last question that before we wrap it up is, how do we think about the impact of these interventions, medications, surgical treatments on voice tremor? Someone terms essential voice tremor. So essential tremor presenting mainly as voice tremor. So
this is one where, unlike the head tremor data, we know that primidone none of the medications have been studied as well as that head tremor data for voice tremor. But there is some effort, and primidone perhaps had an even lesser. I mentioned 40% for head tremor. There's probably about a 25% reduction for voice tremor. There are some folks who will go the distance, and this is worth doing, by the way, because essential tremor, I mentioned the risk of developing Parkinson's, but there are many other movement disorders that can occur with essential tremor. Dystonia is one condition that comes up as a name that we have to take, we have to take into account. We have to make sure that that's not something that's affecting an essential tremor patient day in, day out. And to that end, a voice tremor, under quotes, might actually be something called spasmodic dysphonia. Spasmodic dysphonia is a dystonia of the voice that can sound raspy and tremulous, but in fact is not a voice tremor in the traditional sense. And we have ENT colleagues that will perform a scope. They will take a camera and look inside, look at your vocal cords to see if they're behaving that way or if they're just behaving like a traditional tremor. The folks who I have who have spasmodic dysphonia really do appreciate the benefit that subsequently an injection of botulinum toxin will give to the vocal cords, reduce the impact and allow you to speak more clearly. However, on vocal tremor that is not spasmodic dysphonia, it has been almost like a 9 times out of 10 scenario where the voice just goes away. You go hoarse for the better part of 6 weeks before you start to regain your voice strength, but the tremor is still there from the very beginning. 10% chance is what I'm getting at, that maybe it makes a dent for vocal tremor. That's worth continuing, but it has not been our experience that that's better than a 10% chance of some reduction worth doing.
Yeah, thanks, Dr. Roque. It's critical to establish the diagnosis once voice tremor seems to be the main presenting symptom. And there's some impact, as Dr. Roque mentioned, from medications, and certainly from interventions. And we'll cover that in our next webinars. Both DBS and focused ultrasound seem to make a difference in terms of reducing head and voice tremor. So while we wrap it up, there's another question, and I feel like I can summarize this. Someone asked a question about what are some of the things that someone can do before a particular, say, event or something to reduce tremor. And so there are some lifestyle modifications that people in general do. Exercise, we say, is always good, right? Building the muscle strength is always good and helps with tremors, may help with tremor up to a certain extent. Avoiding caffeine, for example, someone asked this question, avoiding caffeine just before an activity where you would have to use your hands is important. And then, when we talk about stress, so mindfulness meditation, and so if there is a way to manage stress, in general, it could have some impact on the tremors as well. So these are some of the things that we think can be of use while you are managing around essential tremor. Dr. Roque, any further thoughts on this?
No, those are exactly right. I mean, short of trying to use medications or, as some may have discovered, alcohol to help, like, for a given moment, it doesn't work for everyone, just like the medications that are temporizing don't work for everyone. But sometimes there are techniques like that if you're approaching a particularly stressful scenario or event where you're in a public space, performances or otherwise. There are ways to kind of think about first, like, think of it more as you're trying to reduce the stress first, as Dr. Krishna was alluding to, so that that's less impactful on your tremor while you're in the activity. And so there's quite a bit conservatively there, as was mentioned. Sometimes medications can help along the way, along with what I mentioned here, but even other scenarios, quite frankly, too. It could be more than that. So other kinds of medications, but it's all meant to reduce the mood, reduce that impact.
Thank you. I think we had a great discussion today. Excellent participation. We're really grateful. These questions help us, get the conversation started, get the information out there. So thank you again.
Yes.
Thank you, everyone, for joining. Thank you, Dr. Krishna and Dr. Roque, for taking time out of your day. And we look forward to seeing everyone here soon.
Thank you.
Thank you all.